My name is Matt Lynch. I am the director of the Global Program on Malaria at the Center for Communication Programs at Johns Hopkins School of Public Health. We work on behavior control interventions to improve public health across the world, but particularly in sub-Saharan Africa. The Voices Project is a malaria advocacy project that's funded by the Bill and Melinda Gates Foundation, and we're now in the third year of that project, looking to increase the resources available for malaria control. And so those resources would include money, people, technical skills, and attention and political will to malaria as a problem. Well, 25 years ago I was a Peace Corps volunteer in Kenya. And then following that time I worked for 5 years in central Tanzania managing a research project on eye disease. But at that point it became pretty clear to me that malaria was a huge problem. Every rainy season several people from my team would be sick for several days over a couple-month period from malaria. Their kids would be sick, their families would be sick. When I came back from Tanzania and went for my PhD, malaria seemed like an area that was starting to pick up, that had some interesting interventions coming into it, and was intellectually exciting. So as well as addressing something that I felt was a real problem in Africa and could potentially have a real impact. It has a tremendous impact, frankly. It really goes across all of the different aspects of life, and particularly for rural households. First, the malaria tends to come about 6 to 8 weeks after the rain. That's about the time you need to get out and do the first weeding of the corn crops. So at that point in time, suddenly you need a lot of people out in the fields in order to be able to get a good crop, and boom, your family is sick from malaria. Not only do the kids get sick, but mom then has to take time to take them to the clinic in order to get treatment or to the shop. That takes a whole day away. There's money involved in getting transport. There's an additional burden on the mothers of the household, the caretakers of the young children, to take care of these kids, to find the cash, to get them to the place, to be able to get the drugs. It imposes a huge burden on the family, both financially, in terms of their agricultural productivity, in terms of the mother's time. And mothers in Africa tend to be very busy people. Malaria treatment has a long history. Basically, quinine was discovered by the Jesuit missionaries to South America in the 1600s, I believe. It was being used by the Native Americans in South America at that point to treat fevers. Very effective. Continues to be effective to this day, although we reserve it for treatment of severe malaria. Other treatments that have come along in the 1950s and 60s, chloroquine was the treatment of choice. It was a great drug. It was cheap, it was safe, you could get it almost anywhere. It could be manufactured in a wide variety of places and countries, and unfortunately, because it was such a great drug, it was effective, it was cheap, it was easy to take, it got used very, very extensively, and over time the parasite developed resistance to the drug. Starting in Southeast Asia back in the early 70s, I believe, and then very rapidly spreading across. At this point, chloroquine is almost completely lost as an effective malaria treatment. Through most of Africa, it's less than 50% effective. So it's gone. In replacement, we now have a new class of drugs based on artemisia, which is a traditional treatment from China. It's been known for many hundreds of years, which can be refined and produced into artemisinin combination therapies, or ACTs. These drugs combine artemisinin with another compound with the explicit purpose of increasing the probability that a parasite will be killed by one of the two drugs and decreasing the possibility that resistance will occur over time. Basically what we're seeing on the Thai-Cambodian border is an area which has been the epicenter of malaria resistance since the 1950s, 1960s. We've lost a number of different drugs to resistance stemming from this area over time. In that area, there's a particularly complex ecosystem for the disease. You've got outdoor biting vectors, you've got a lot of illegal gem mining and forestry going on, you've got mosquitoes that are biting in the forests, and so a lot of transmission going on. There's also a very vibrant informal private sector, so a lot of drugs being sold, many of which are poor quality, either don't have the appropriate amount of active ingredient, or are artemisinin monotherapies, where it's just artemisinin without the additional drug to prevent resistance. So what we're seeing is that a lot of people are continually dosing themselves with low doses of artemisinin. They're getting reinfected frequently, and that ends up providing a perfect opportunity for the parasite to develop resistance. What we need to do now is to get those monotherapies off the market, and that's the newest push from WHO, and it's something that we're working very hard as a community to try and address now. Well, one of the really exciting things that's happening right now is we've got a new set of diagnostic tests. In the past, basically most of the doctors in Africa, and actually in a lot of tropical countries, had to just look at a kid with fever and decide whether or not it was malaria. And chances are fever ended up being equated with malaria. So we were treating lots and lots of kids with anti-malarials just because they had a fever. We now have rapid diagnostic tests where you can prick the kid's finger and within a minute or two get an answer as to whether that's actually malaria. With that, we're able to reduce the number of inappropriate treatments with anti-malarials by a huge percentage. And this means that we can reserve those anti-malarials for kids who actually have, or people who actually have malaria. So this means that we're much better able to target the treatment. We're working on a new subsidy through the Global Fund, which will provide artemisinin combination therapies, the ACTs, at a price that's lower than the competing drugs, and in this way we hope to drive those substandard and artemisinin monotherapies off the market with basic market dynamics. So I think with those two advances coming in, we have a great chance of being able to improve the availability and the effectiveness of treatment in rural communities across the world. Malaria is a huge burden on the part of our population that is the least well prepared to deal with it, the most vulnerable. We're talking about rural households, we're talking about poor households, we're talking about households who are living on the margin. And these households are the least well equipped to deal with sickness and death. And that's what's happening with malaria. Malaria is increasing the burden on the households, it's decreasing their ability to progress, it's decreasing their ability to move forward. Malaria has impacts on education, it has impacts on agriculture, it has impacts on women's time. All three of these together provide an intolerable burden that really needs to be addressed. And we have the tools right now to address that. We don't have to wait. We can do a whole lot right now to end these deaths, to end this burden, and to lift this burden off of a very vulnerable population.